Good evening, all, respected seniors and all the members of IAP Trivandrum, and welcome to you all for yet another episode of Tuesday's series. And I welcome Kalpana Madam, Riyaz Sir, Purushottam Sir, and other seniors who had already joined for this program. And today we have discussing a very novel and important topic of hospital infections and hospital hygiene practices that usually we have not discussed previously in this platform series also. And we have a guest faculty, Dr. Jyothi Madam also. Welcome Jyothi Madam and welcome Bennett Salem for this academic event. And I invite Kalpana Madam for continuing the session.
Dr. Riyaz, IAP President Kerala is here, and welcome Riyaz for telling a few words. Riyaz, are you here?
Yeah. Thank you. Thank you, madam. So, I think we're taking up a new topic. Like always, we think about curing diseases. Now, this is more important, like how to prevent the infections in hospital. And I think it's a duo of a clinician and a microbiologist talking to us. Both of them are very dear to us, Bennett sir as well as Jyothi madam. And Jyothi madam is behind the antibiotic stewardship program in the state, and which is getting a lot of laurels from all over the country. So I think ma'am will be telling something about that also. And Bennett sir can give glimpses from his own long clinical experience. And he's a military man also, so he may be telling about what is happening in the forces hospitals also. Okay. So all the best for the academic program. I wish all the best to both the speakers. Thank you.
So good evening all. Good evening Riyaz, and good evening Dr. Bennet, Dr. Jyothi, and all this, Dr. Purushottam sir, and all the seniors here. And we are going to the infection prevention practices, as Dr. Riyaz has mentioned. And actually, this is a very, very important problem, and we can say that when we are doing more and more new, even the transplants are being done in the government hospitals as well as private hospitals, and there are so many problems because of the secondary or hospital acquired infections. And once it happens, there will be more problems like this litigation also will come, isn't it? So this is a very important topic for any clinician, not only pediatrician, for any clinician or any hospitals, government or private. It is a very important problem. And now the government has come out with so many. This antibiotic stewardship program is a very laudable program, because now we cannot get an antibiotic without a prescription, and thus it has reduced the use of antibiotic to a great extent in the public. And so I'm not telling more. We can hear from Dr. Bennet Xylem, who is the National Executive Board member of Central IAP. And also he has just retired from the government service as the senior consultant pediatrician. And now he has joined Jubilee Mission Hospital. And he's always he's interested in the public health problems, and he always comes with a solution also. And Dr. Jyothi is additional professor of microbiology in Government Medical College, Tirunelveli, and she's a very well-known microbiologist, and we'll hear from her also. And we'll be discussing after both the talks. And over to Dr. Bennet Xylem. He doesn't need an introduction.
Yes, ma'am. Thank you very much, madam. Thank you for giving this opportunity. And especially thanking Dr. Jyothi for being a backbone for this topic, because it's mainly done by microbiologists. It's an experiment for me. Fortunately, I started this program, like giving teaching to health service doctors since 2006. That time, because of the HIV dominance, the topic was taught to us. We had a TOT, Basically, 3-4 topics were there. One is waste management. One was waste management, and another thing is for infection prevention practices and safe injection practices. So everything is now together. I put it in this slide, and supporting this, the microbiologist point of view will come. I will share this topic before starting it. Okay. Okay. Can everybody see this?
Yes, yes, sir.
Okay. See, so basically about the topic, I like to say certain few points. See, everybody talk about infection prevention and all, but practically all are doing it. That is the most important thing. When I was studying MBBS, I was in 83 batch in Trivandrum. I think Kalpana madam was 2 years senior to me. And that time, what we used to see in our wards is there is a screen was there. Towels were kept there. Anybody who washes their hands, they wash their hands, then they will go and wipe this using this common towel. It was a total, there is no prevention of infection. That time always there is an infection chances are very high. And in Trivandrum Medical College, we can see that we were seeing that near the mortuary, all the waste were dumped there. But these things were not there nowadays because of the improvement of the health status. And definitely we should thank IMA, Indian Medical Association Go Eco-Friendly Image, for organizing the waste management process. Keeping that in mind, let me talk my topic. See, it is a very important topic, even though it is little dry for a clinician. But this is the most important topic because any child or any patient come to us with only one reason. They want to cure the disease. They want to cure the illness. It is not correct, and we should give an infection to them. And more than that, it is not correct that we should get an infection. So this is the only one important topic. Most of the topic what we discuss is we should give more importance to the patient. Here the importance is given to both patients and for us. So it's equally important. So these are the beautiful words from Mahatma Gandhi. The earth is enough for everyone needs, but not enough for some people's greed. So it is a problem of greed. That is a thing we should remember. So you can see that in Kerala, the roads are very good, extremely good, especially nowadays. But unfortunately, what is happening? Once you make a new road, a lot of waste will be dumped in that good road itself. That thing we should keep it. So this is the word of Gandhi. There's enough for everyone needs, but not enough for some people's greed. Keeping that in mind, let us go to our own topic. So coming to the infection, you all know that for any infection, there is an agent. Agent can be of anything like fungus, bacteria, and virus. That is the thing and of course, protozoa also. Practically, we normally talk about virus and fungus. There is a reservoir. The reservoir can be above we only, like we only giving the infection, or the patient is giving the infection to others. See, fortunately, because of the COVID, we know that the infection control is very, very important. It has given even though it started from HIV days onwards, nowadays we are not talking much about HIV, but the importance was erased when the COVID was there. So always there is a reservoir to get an infection. There is a place of exit and there is a mode of transmission. There is a place of entry, and who will be affected? It can be a susceptible host. Who is susceptible host can be we only, or our patients, or anyone who come to our hospital, including pregnant ladies. That thing we should remember. See, even though pregnancy is a normal process, but there is some amount of derangement in the immune system of the pregnant ladies. For anybody who is coming to our hospital, except immunization, they are having some derangement in immune status. So they are the susceptible hosts. So we have to give importance. More than that, even for any child who is coming to immunization, he coming to us as a normal child. and suppose if he is getting infection, it is totally incorrect from our side. So these are the importance we should think. So where we can cut this thing? Anywhere, all these places. Agent you can kill. You can kill by antiviral or antibacterial. Reservoir you can get. You can clean it properly, the reservoirs, or if you behave yourself, the reservoir source can be reduced. Place of exit, again washing of hand is important. Mode of transmission, again washing. Place of entry. So everywhere, only one important point, that is even our government also keep on saying through radio, television, including cinema theater, wash your hands. That is most important, so that susceptible hosts will not be affected. So who all are affected? Three people: clients, service providers, and community. See, during classes I used to talk about why this terminology has come clients. Normally we know that the clients terminology used to come in court only. Here also we are going to face the court situation. Why? Because of our improper management of waste, medical waste, and suppose somebody is affected with the HIV or hepatitis B, mainly HIV will not affect that easily. Hepatitis B, hepatitis C. If somebody is getting hepatitis C because of our improper waste management, then that means, suppose if we come to, if the court comes to know that it is because of our institution or because of the doctor or because of the nurse, or maybe, then they can be sued and it will be penalized. So that is the importance. And who is service providers? We only. We get infection. Who is the community? It was there. Like olden days, I said during our MBBS days, everywhere or near the medical colleges, the waste was dumped. So many animals used to come there. So many people used to come for collecting the syringes which was used there, so that they can sell it and make money. That type of thing. Suppose somebody is getting infection from the community also, they can also get sued. So that is the problem here. So we have to be very careful about this situation. How it is getting transmitted? We know that because of the code. We know that the transmission is only because of these three things: contact, droplet, and small particles airborne transmission. Here we have given more importance during COVID scenario. That is the reason, if possible, avoid the nebulization process. Nowadays, IAP always recommends better avoid nebulization. We always prefer to give inhaler therapy only. And nebulization, unless it is an emergency, you can give. But otherwise, better not to give nebulization, because there is a production of small particles through airborne, and so that way the others also getting infections. This is the only one gold standard for prevention of infection, that is hand washing. Hand washing is a must for any program or any procedure. So why we do hand washing? We know that there are different floras in our body. We know that there is a brain, then gut microbiome is there. Microbiome is there. It is very, very important. Similar way, our transient flora and resident flora. Resident means resident. It is there in our body. It is required. It is because of this microflora only we are living. So it is we cannot remove that microflora. It is required. There is a transient flora is there. Transient flora is like, suppose an example I will tell you. When we are going to a hospital, different places we get a contact. Like suppose somebody is traveling in a public transport, from the house they come out and using a public bus, you holding the iron rod, then in between they used to shake an attendance book. So everywhere different contacts are there. So that this flora, this transient flora, any organism in that surfaces will get contacted, and definitely we will get that infection. But nothing will happen because our immune status is better. Resident flora, it will not be like that. It is there with us only. So, but for doing any procedure, especially surgical procedure, especially if you are seeing a blood, then definitely you have to do the hand washing, which can protect both the client and provider from the injection. So from the infection. But normal situations, even for ward work, once you come to the hospital, if you are entering a ward, if you are going to start to see a child, or a patient, definitely you should do initial hand washing so that you can remove the transient flora. But for surgical procedures, you have to do the resident flora also you have to go, remove. That is the reason we have to do using a sterile precautions. So when to wash hands, it's written so many things, but like I will tell you easily what should we should remember. Coming to the hospital before starting your work, do a hand washing. Going out of the hospital, do a hand washing. In between, any contaminated things you are contacting, definitely hand wash it. When you see a patient, especially is infectious patient, definitely you should hand wash it. In between, so ideally you should do a hand washing with the soap and water, but in between you can use a or sanitizer with the 70% alcohol. You can use it. That also can be easily. You can remove the organisms for a normal level of clinical examination. So this is the different step. This I will go a little fast because see, this is everybody knows that there are 6 steps of hand washing. Step one is wash palm and fingers. That you see, you have to use the in between fingers also. Then palm to dorsal surface, washing fingers and knuckles. Then thumb, because thumb always in a separated area, so that to be separately washed. And tip of fingers in a rotatory movement, you have to wash it. Then wrist, medial surface of the hand and wrist together, you can wash it. So 6 steps. See, the steps are very important. And most important thing, why these 6 steps? 6 steps because, see, if you do a normal hand washing like this, everywhere will not be, the soap and water will not be touched. So this, because the wrinkles will be there. So, removing these wrinkles and contacting with the surface of soap and water, you have to stretch like this. Then only you can touch all the places. That is importance. So 6 steps are very, very important. So remember, hand should always be washed whenever gloves are removed. This is another common mistake we may do. Like we say, okay, I use the gloves, so no need of any washing and all. It's not like that. Micropores may be there, so there may be some injuries will be there with the gloves. So even after using gloves, you should wash your hand. This is a gentle reminder. It is very, very important. And this is a common hand dry. See, this is the hand personal towel. For a normal day work, like you are not in a sterile precaution level, even simple, normal personal towel also can be acceptable. But ideally, even personal towel is not acceptable. Ideal thing is, electrical hand dryer is the most ideal, or if nothing is there, even simple air dry is enough. No, like no blowing of with your hand with your like shosam or your respiration and all is not correct. And you can use the personal towel also, but never use the common towel. Hand drying, these are different methods. Electrical drying will be ideal. Hand hygiene, this is everybody knows about it, so I am not concentrating on it. 6 steps is most important. This is another thing. This is why, where to use it. Personal protection equipment. That is, this is important. Here comes the gloves, mask, eye cover, plastic aprons, gowns, cap, footwear. This we religiously followed for COVID, but not otherwise. But ideally, this should be followed everywhere. We are following it in a surgical situations. Practically in a ward work, this is not required at all. But in a surgical cases like in theater and all, it is also again required. This is the most important slide and interesting slide for me because I marked it red. We got a different slides. That is surgical gloves. Everybody knows about it. Single-use examination gloves. Usually gynecologists use it for single use and throw. And utility or heavy duty household gloves. This is very, very important both in government sector and private sector. I will tell you an example. Suppose a good hospital, and let it be private or government. Especially, I like to quote the government hospitals. Suppose one person on quality wise working in cleaning staff, if she uses a surgical gloves, she has to use minimum 5 gloves per day. Minimum five gloves means if you quote the cost of one gloves is 20 rupees, minimum 5 gloves means 100 rupees. So if you spend 100 rupees for one day, suppose 10 staff are there, they are using around 1000 rupees per day. Over a period of 1 month, it will be 30,000. So that much expensive. But the same time, same person using a heavy duty household gloves for cleaning purpose, then the each gloves cost will be around 300 rupees. That can be used for minimum 3 months. So it is protective also. It is alkali resistant, acid resistant. Minor injuries can be prevented using a heavy utility gloves. So we should recommend only the cleaning staff should use heavy utility gloves. Surgical gloves can be used for procedures, especially done by doctors and nursing staff. Any cleaning staff means it's a heavy duty house or household gloves only. About mask, I am not concentrating because different layers of masks are there, 2 layer, 3 layer, and all. We know that N95 mask is there. The recommendation is at least you should use a mask. Before examining or on examination of a patient, always use at least any one mask. That is most important. Of course, in a particular situations like our COVID scenarios, and we use N95, but finally, because of the economy reason, we come to the level of at least 3 layer mask. What I suggest is minimum, at least you should use a one mask. That is most important. And footwear. This is again very important thing. Footwear. Here, I am not reading the slides. My point is always if there is a blood shed procedures like during in the labor room, especially for a gynecologist. I know that gynecologist will not be there in our group, but gynecologist or nursing staff, anybody is there. What we should remember is always use a footwear with a plastic shoe. Why plastic? It can be easily washed. Why not leather shoe? The blood content will not be removed easily. And why not chapel? Again, blood spillage will be there. Small abrasions will be enough to get a hepatitis B or hepatitis C. So better always use a covered footwear. Ideal thing is up to ankle boot or up to the level of knee boot, knee level. That will be ideal. See, only one thing is people will say that, or doctors will say that, or nurses will say that it is not easy to use it. But I can tell you, definitely we can use it. If you use it every day, we don't feel like it's a hectic thing. And practically, I am using it for my farming purposes and all. Every day I use that only. There is no problem at all if you use an ankle boot. This is a mask of how to wear and all this slides I took during the COVID scenario. I am not planning to explain this. Also steps for donning and hand rub before each step. I think everybody knows about it, so I am not concentrating on donning and doffing in a single slide. And this is another important slide. So antiseptics and disinfectant, these are the preventive chemicals we can use it for prevention of infection. So what is antiseptic? What is disinfectant? Very simple. Antiseptic means a substance which can be used over a live subject, like human body, animal body, anywhere. If the live surface, jeevanulla pratalam, live surface, if you can use it, that is antiseptic. Disinfectants means it is not used in a live surface, basically for instruments cleaning. Either it can be sterilization or disinfection. So what is high-level disinfection? It is destroys all microorganisms except some bacterial spores. Means Purnamaya Anuvimaktada in Malayalam. But high-level disinfection does not mean that it is sterilization. Sterilization is different. Sterilization is Paripurnamaya Anuvimaktada. That means it destroys even spores. Any surgical procedures, any blood shedding procedures, you require sterilization, not high-level disinfection. So intermediate disinfection means inactivates mycobacteria, tuberculous vegetative bacteria, most viruses and most fungi, but does not always kill bacterial spores. Low-level disinfection, what we normally uses in our house and hospital surfaces, like waiting area and all, can kill most bacteria, some viruses and some fungi, but cannot be relied on to kill more resistant bacteria such as Mycobacterium tuberculosis or bacterial spores. Basically, the purpose is for cleaning surfaces like Lysol and all. Anyway, antiseptic is already said, so I am not wasting my time. Chlorine solution. This is our Ottamuli we used to say in Kerala Health Services because easily available, economical, nothing. But what are the advantages? A lot of advantages are there. It destroys microorganisms. It deodorizes. It's not a poisonous thing. Leaves no poisonous residue also. It is economics and colorless and easy to handle. These are the most important things in a chlorine solution. We cannot keep away this chlorine solution. I know that private hospitals may not be using it, but chlorine solution is the most ideal thing because it is economical. We are in a developing nation, so we have to think about all these things. So, what is a mathematics? It's a simple slide. Once I finish this, anybody wants to take a screenshot, it is better you can take it. It is good, and only one slide I like to say like that only. See, this is a chlorine content labeled in a packet. That is 33.3%. It is commercially available. 1 gram in 1 ml water is 33.3% only. And 1 gram in 10 ml water is 3.33%. 1 gram in 100 ml is 0.333%. And 1 gram in 1000 ml is 0.0333%. That means practically it is 1 gram in 1 ml is 0.3033%. Okay. So 30 gram in 1 liter means it is 1%. So how will you prepare this? It's a 15 gram good quality bleaching powder. Take needed amount in a plastic bucket. The way of preparing it: pour some water, make a paste, then add rest of water slowly through the side. Gently see that there are no particles left. See, here I like to say certain things. Ideally, how will you mix the water and bleaching powder? Ideal way is use a hand only. But practically, once you use a hand, your hand will get burnt. So you must use a heavy utility gloves. But some program, I think, let's say, or some programs, it is now recommendation is using a stick and all to make it as a paste. But most ideal will be the hand using. But once you use it a hand, always use a heavy utility gloves. Otherwise, the hand will get burned. Initial, when we got the teaching, it was the recommendation was using a hand only, but with the gloves. This is the way. One second. Wait a second. Please, sorry. Okay. Put used items, then in a 0.5 ml chlorine solution after use. Remove after 10 minutes. Like I will tell you on the small disturbances there. Okay. Then this is for cleaning of our instruments. So how will you clean these instruments? That put used items in 0.5 ml chlorine solution after use, remove after 10 minutes and put it in a bucket. This another slide is there. In that slide, I will explain it more. That will be more easy. These are the another solutions which can be used. One is ethanol, then providone iodine, formalin, glutaraldehyde, hydrogen peroxide. All these can be used. So 1% hypochlorite solution, how will you make it? That is the thing I explained. That is the 30 gram in 1 liter of water, you will get a 1% hypochlorite solution. And you can use a 3-bucket system, high touch areas more often after. See, what it is mentioned is mainly, see, if it, you can, once you prepare the chlorine solution, keep it for some time. That supernatant fluid, you can use it for the our cleaning of instruments or surface cleaning, anything you can use it. But once it get more and more like contaminated, you can remove it. Otherwise, you can keep it for a maximum of 24 hours. This the cleaning agents and disinfectant freshly prepared is 1% sodium hypochlorite solution. Okay, this is the processing of instruments and storage. So, like our dining utensils, we used to wash. How it is washed, like chotupatra. We used to keep it inside the water for some time. That process you can compare with a decontamination. Then cleaning. Use a normal, simple soap is enough. Then sterilization or high-level disinfection. Then storage. First step, see, one slide is there. I will take that slide and I'll explain everything in that. So that time we can save it. This slide is enough. Please concentrate on this slide. See, first process is decontamination. Here, instead of 1% solution, you can use it 0.5% chlorine solution. So only thing is, instead of 30 gram, you can use it 15 gram. So you will get a 0.5% chlorine solution. But there is a controversy. Things are there. Some program they say that 1%. Some program they say that 0.5%. Whatever may be the program, the basic principle is same. How to prepare is same. That is 30 gram, you will get a 1%. For 15 gram, you will get a 0.5%. So keep it in that fluid for 10 minutes. After 10 minutes, if you keep it, it will get erosions. So better avoid after 10 minutes. Thoroughly wash and rinse, wear gloves and this. Then you take it for high-level disinfection. So what is high-level disinfection? Here again, it is very, very important. It is a Sidex solution only. Here, once you keep your instrument for 20 minutes, it is a high-level disinfection. But the same thing, if you keep it for 8 to 10 hours, it is a sterilization. So it is a chemical high-level disinfection if you keep it for 20 minutes. It's a chemical sterilization if you keep it for 8 to 10 hours. So anywhere blood is there, you have to use a sterilized instrument. But if it is not there, like vaginal sound, scopes like esophagus scope, rectoscope, proctoscope, all these things, there is no need of any sterilization. High-level disinfection is enough. Two ways there. One is chemical and thermal. Where you can use it if there is no sharp instruments, you can use a thermal high-level disinfection and thermal sterilization. Thermal high-level disinfection is done earlier days in our wards. There is a square form of thing is there. People used to say that it is a sterilizer, but it is not correct. It is a boiler. What is sterilization? It is an autoclaving. Boiler, if you get it as a high-level thermal high-level disinfectant. So how to do that is, in the boiler, keep your instruments inside, put water and close the lid. Then boil it. The boiling should be continued for 20 minutes. Then only you can say that it's a high-level disinfected instrument. About high-level disinfection for a chemical and for high-level and sterilization, see, the chemical substance is there inside over the instruments. How will you remove it? See, during our teaching programs, I used to ask this same thing to our doctors and nurses. They used to say that they used to wash it with a normal saline, but it is incorrect. Normal saline means what? It is a medicine. So you are not supposed to waste a normal saline. This can be cleaned, high-level disinfected, chemical disinfectant instrument can be cleaned using a high-level thermal disinfected water. Similar way, sterilized high-level chemical can be removed using a autoclaved water. So no need of purchasing anything. So this is advantage. Now we will go to the housekeeping. This is simple. Every day we are doing it. It is the only thing is you have a low-level disinfection only. Purpose I am not going to tell because we all know that. These are all self-explanatory. Now I will go to a picture. So this is the thing. Suppose if you get a spillage of blood, how will you handle it? Put a cloth over it. Then pour our highly disinfectant solution. What is that? Simple thing, chlorine solution. Put a 1% chlorine solution over it. Keep it for 20 minutes. Then it becomes high-level disinfected surface and high-level disinfectant area. Then only you are supposed to remove it. The normal tendency is whenever there is a spillage, immediately cleaning. That is not the way. You should you should make it as a high level disinfected area. Then only you are supposed to clean it. Use and disposal of sharps. This is simple. Injection needles, suture needles, all these things. Anything which is sharp. Which is to prevent injuries. Like now I will go to the needle stick injuries. Mainly the risk exposure is hepatitis B 20 to 30%, hepatitis C 3 to 10%, this is HIV. So we should not bother. Now I know that everybody knows that HIV is not that big problem. Our main problem is hepatitis B and C. HIV is only 0.3 to 0.4%. There is a study, especially in HIV early days. We normally think that HIV chances will be very high with the surgeons than a physician, but unfortunately it was happened in the other way around. Because surgeons, day one onwards, they know how to use all these things. But the physician, like pediatricians and or general medicine physicians, the normal days we are little careless. So we are little careless. We think, chalega. That type of attitude we got. But so the incidents occurred more with the physicians than the surgeons. Surgeons are more careful. So any sharp injuries there, flush the area, irrigate, and the ideal thing is for like a rabies dog bite, you with a soap and water washing is most important. Then PEP, that is post-exposure prophylaxis for hepatitis B, immunoglobulin, and hepatitis B vaccine. For HIV and ART within 2 hours of prick. For hepatitis C, no PEP is available yet. Use of multi-dose vials. Never change needle without changing the syringe. Here, the present recommendation I will tell you, any sharp objects, if you want to hand over to another doctor, especially in theater and all, you keep it on our surface. Normally, what they do is they keep it inside a tray. Then the other doctor will take over the thing. We are not supposed to pass the sharp object personally. Okay. This is a biomedical waste management. See, this is the footnote is very, very important. Spit at heaven and you will get it back in your own face. So if you are not, that is a thing. It's sad to see that our public places, good roads are there, good places are there, beautiful places are unfortunately, a lot of waste is dumped over there. But fortunately, that thing is not happening in our hospital scenario because of the image, only because of image. Now I'll go to the last slide. It's a biohazard symbol. The waste disposal, the importance of proper waste disposal, different types of waste and disposal. Now I'll go to the last slide because that is most important, and so that Dr. Jyothi can also discuss more things. With the last slide, I will tell you about this. See, this is the color coding. I never remember these color coding because each institution has got a different color coding. So basic principles I like to highlight here itself. See, here you can see that there is a black bucket. See, the initial disposal of the waste is the responsibility of the person who is creating the waste. It is not the job of a nurse or an attendant or a cleaning staff or anybody. It is the responsibility of the person who made the waste. So practically, suppose we are giving injection, we remove the cover and everything and we'll keep it everything. It's totally incorrect. We should change our mind. It is our responsibility. So initial segregation is our responsibility. Terminal is the designated persons will be there. So 85% of the hospital waste is general waste, not the biomedical waste. Only 15% is biomedical waste. We are bothered about this 15%. So this 85% will come here in the black bucket. Here, now in Kerala Health Service, it is divided into 3. I am not fully remembering all the colors of these 3 buckets, but it's different 3 buckets are there. They keep it as a plastic in one bucket, paper in another bucket, and green bucket is for food waste, like decaying wastes. That is the ideal way. Actually, from initial days onwards, I used to say that it should be split into 2 at least. So now made it into 3. That is a beautiful thing, and that should be followed everywhere. That is for the general waste management. Here it is easy to remember. like human, we will totally go to the nature, like by burning or by burying, whatever may the thing. So same thing you can do it here. Any waste which is generated from the live body, you can put it here. Pus, you remember like that. Pus is yellow. So anything which can be incinerated can be put in the yellow bucket. Blood containing plastic, you should keep it in the red bucket. And nowadays, there are blood containing, like we think that it's a plastic, that is like blood bags. Some blood bags there, it is biodegradable. That is again will go to here. Anything which is biodegradable can be put in the yellow bucket. Sharps, we can use it for the blue bucket. Again, I like to tell you, it is not blue. What you remember is in hospital, there is a specific protocols there, which item to be put it in which bucket. Once you are attached to the image organization, they will guide you in what bucket you have to initial segregation to be done, and final segregation will be done by the designated people. Thank you very much for patient hearing. And after Jyothi's discussion, we will have a good discussion about it. Thank you. Thank you very much. I'll stop here. Jyothi. So,
Thank you, Bennett. We'll directly go to Dr. Jyothi, and after that we will discuss.
Good evening, madam. Thank you for giving me this opportunity.
Jyothi is our faculty in medical college, and she has done a lot. I don't know personally, Jyothi, but I have heard about you a lot. And you are Jasmine's classmate and Dr. Mini's classmate also.
Thank you, madam.
Let's go on with the talk.
Okay. Thank you, madam. Thank you for giving me this opportunity. I am going to brief about this AIPC and my experience, microbiological point of view. And
Okay.
കാണാമോ madam? കാണാമോ?
Yes, full screen ആക്കണം. First slide. This
Okay.
is second slide that is there. Okay. Yes, it is visible.
First, about the healthcare associated infection. Burden of HAI, according to WHO, 7% of patients in developed countries and 10% in developing countries. In this 10% of affected patients have high mortality. The source of infection, endogenous source and exogenous source. Endogenous involves patient's own flora, and exogenous environmental surfaces, inanimate objects, air, water, or food. Then healthcare workers, hands of healthcare workers harboring, this is an example only, harboring MRSA and other patients. So these are the very important 6 pathogens. They are known as escape pathogen. They are known as superbugs. They are multi-resistant organism. These are Enterococcus faecium, then Staphylococcus aureus, mainly MRSA, Klebsiella pneumonia, Acinetobacter baumannii, Pseudomonas aeruginosa, Enterobacter species, and these are also involved in hospital-acquired infection, Escherichia coli, SARS-CoV-2, COVID-19, nosocomially acquired Mycobacterium tuberculosis, Legionella pneumonia, pneumophila, Candida auris. Candida auris is a very recently emerging Candida infection, and others, Candida albicans also, Clostridium difficile diarrhea, and another one very important bacteria is Stenotrophomonas, and bloodborne infection like HIV, hepatitis B and C. These escape pathogen, they are multi-drug resistant organism.
Staphylococcus, Enterococcus faecium,
Staphylococcus
Staph aureus,
aureus.
Acinetobacter.
Please mute. Some others' microphone is on. Okay.
And next,
Jyoti, you can
the
continue.
transmission routes. What are the important transmission routes, modes of transmission? Dr. Bennett has already discussed. And first one is contact transmission. HAI, healthcare associated infection transmission by direct or indirect contact. Direct contact from one person to another person without any contaminated intermediate object, and indirect transmission through contaminated intermediate objects like clothes, patient care devices, environmental surfaces. Then these are the organisms which are transmitted through contact. Multi-drug resistant organism like MRSA, carbapenem resistant Enterobacteriaceae, which include E. coli, Klebsiella. Then what is crab? Crab is carbapenem resistant Acinetobacter baumannii. Then vancomycin resistant Enterococci, and multi-drug resistant non-fermenting gram-negative bacteria, which include Pseudomonas, Stenotrophomonas. Then enterically transmitted hepatitis viruses, HIV and HEV. That is hepatitis A and E virus. They are transmitted through contact. Then agents of, and also fecal-oral. Then agents of conjunctivitis, adenovirus, gonococcus, chlamydia, contagious skin lesion, group A, Streptococcus, Staphylococcus aureus, skin infestation, that scabies. Then agents of diarrhea causing viruses like rotavirus, cholera, Vibrio cholerae, Clostridium difficile, and noroviruses. So what are the contact precautions by which we can prevent this transmission route? By hand hygiene. Always hand hygiene is the gold standard for preventing this healthcare associated infection. Then wearing PPEs, then single-use patient-dedicated equipment, patient placement, then transfer of patients, and disinfection of rooms. Next, about the droplet mode of transmission by respiratory droplets. Here, large particles, more than 5 micrometer in size, are generated by patient during coughing, sneezing, and talking. And this transmission, via large droplets, they require close contact, less than 3 feet. They will not remain longer period in the air. It will not remain suspended in the air, and it travels shorter distance only. And the agents are Corynne bacteria, diphtheria, Haemophilus influenza type B, Neisseria meningitidis, Bordetella pertussis, Yersinia pestis, Mycoplasma pneumonia, influenza viruses, then a COVID-19 virus, viral hemorrhagic fever causing viruses like Lassa, Ebola, Marburg viruses. Other viruses include mumps, parvovirus B19, rhinovirus, rubella, and adenoviruses. What are the droplet precautions? Again, hand hygiene, wearing PPEs, respiratory hygiene or cough etiquette, patient placement, then transfer of patients. What are the precautions we have to take during transfer of patient, and disinfection of rooms. Then next mode is airborne. Airborne transmission. These are aerosols which have less than 5 micrometer. They are less than 5 micrometer particle generated by an infectious procedure, and during certain aerosol generating procedures, these smaller droplets, they remain suspended in the air for long period and may disperse to a distant place along the air current. These are the aerosol generating procedures: endotracheal intubation, open respiratory and airway suctioning, tracheostomy care, cardiopulmonary resuscitation, sputum induction, and bronchoscopy. Agents include Mycobacterium tuberculosis, measles virus, varicella, smallpox and monkeypox virus, aerosol spore-containing powders which include Bacillus anthracis, then Aspergillus spores. These are the very important agents which are transmitted through aerosols. The airborne precautions are wearing PPEs, mainly N95 respirator, then patient placement in separate isolation room, then ventilation, and also transfer of patients. Patients should wear surgical mask, then respiratory hygiene and cough etiquette. Visitors and staffs are restricted. These are the airborne precautions. And for all these, we should adhere to the standard precaution. This is the main precaution, standard precaution. We should stringently adhere to this standard precaution to prevent infection spread. IPC practices to prevent transmission of diseases. This measure should be followed when providing care to all individual or specimen, all needles and sharps. And standard precaution include hand hygiene. Hand hygiene is the gold standard preventing transmission of infection. Then personal protective equipment, respiratory hygiene and cough etiquette, prevention of injuries from sharps, safe handling of patient care equipment, principles of hand asepsis, then environmental infection control by patient placement, environmental cleaning and disinfection of linen and laundry, and waste disposal. These are the standard precautions which are involved in infection prevention and control practices. First and the very important gold standard, that is hand hygiene, already discussed by Dr. Bennet. He has done an excellent session in hand hygiene. And these are the 5 moments for hand hygiene. These are, we are conducting hand hygiene audit in ICUs regularly. And for this, these are the 5 opportunities we are the denominator. What are the hand hygiene auditor? We are examining or we are inspecting these healthcare personnel, these 5 hand hygiene moments, like before touching the patient, before a procedure, after a procedure or body fluid exposure risk, after touching a patient, and after touching a patient's surroundings. These are the 5 moments for hand hygiene. Wearing gloves, very, very important. Wearing gloves does not replace the need for hand hygiene. Gloves do not provide complete protection against hand contamination. Then gloves are just a barrier only, not a guarantee. Clean hands remain the most effective defense against infection. When and how can we use gloves? During examination of ulcerative blepharitis or acute viral or bacterial conjunctivitis, body fluids or infected tissue, fitting contact lenses, use clean gloves, remove gloves immediately after use, perform hand hygiene. It's very important. And this is a pyramid. Glove usage pyramid, where sterile gloves are indicated for aseptic procedures. Then clean examination gloves, they are indicated in clinical situation. Then what are the 6 steps of hand hygiene? He has explained very beautifully. And we should do frequent hand washing. Frequent hand washing is very important. If liquid hand wash or water is not accessible, then we can use sanitizer, but check the quality of sanitizer. Regularly, we should check the quality of sanitizer we are using. Is it the alcohol content is about 70%, should be there or not? check the quality of sanitizer, and we should have the sufficient, all the hospitals should have sufficient liquid soap, water supply, or sanitizer. And these are the 6 steps of doing hand hygiene. These are what these articles should not be there during hand hygiene. And these alcohol-based hand rubs are not effective in these cases. This is only few cases. Clostridium difficile infection, norovirus infection, protozoan oocyst infection, bacillus anthracis. These are the proven ones where alcohol-based hand rubs are not effective. So hand washing is the first and very important. Hand washing with soap and water is a very important step we can do to prevent infection. Hand washing with soap and water before and after entering a patient room. Environmental cleaning and disinfection. Environmental decontamination is the first one. Then cleaning of medical equipment, cleaning soiled bedding, towels, clothes from patients, cleaning and disinfection of occupied patient room, cleaning and disinfection after patient discharge and transfer, prevent environment contamination. We can contain respiratory secretions, biomedical waste management. In these few topics I will discuss. Housekeeping surfaces. These are the 2 very important housekeeping surfaces: minimum touch areas and high touch surfaces. Minimum hand touch areas are floors and ceilings. High touch surfaces, those with frequent hand contact. High touch housekeeping surfaces in patient care area should be cleaned or disinfected more frequently. It's very, very important. What are the high touch areas? You can see a colonized patient and a susceptible patient, and the mode of transmission of this infection through contaminated equipment, then contaminated hands of staff and visitors, contaminated door handles, sinks, toilets, then bed rails and other communal surfaces. And high touch surfaces in patient care rooms, consider these are non-critical but must be cleaned and then disinfected on regular basis. Should be cleaned every 3 to 4 hours. An example of high touch areas are bed rails, call bell, telephones, including mobile phone, TV remote, IV pump, IV poles, then a toilet, commode chair, over bed table, light switches, doorknobs, respiratory and other bedside equipment, computer keyboard and chairs. And this environmental cleaning, frequency of cleaning for common situation, this normal, non-critical surfaces and floors, they should be cleaned 2 to 3 times a day. In our hospital, we have 3 shift duties, and they are doing this 3 shift duty cleaning of surfaces and floors. And mattresses used for patients should be cleaned weekly and after discharge. Doors, windows, walls, and ceiling once a week, and spot cleanings when soiled. High touch areas should be cleaned every 3 to 4 hours. High touch areas, I've already told what are the high touch areas, and it should be cleaned every 3 to 4 hours. Do not use traditional brooms in ICU and OT. Before cleaning, we should ensure the removal of dust by using vacuum pump or by wet mops, and do not use brooms in ICU and OT. Otherwise, this can lead to dispersal of microorganisms in the air from the dust. Use microfiber for cleaning. Floor cleaning, use appropriate disinfectant, different containers and mops for contaminated areas, mop heads to be washed and dried. These different containers and mops should be maintained for contaminated areas and cleaned areas. use appropriate disinfectant. Normally, we are using 0.1% hypochlorite for cleaning floor, but before cleaning, should do removal of dust and then clean and then disinfect, clean with detergent and do disinfect and clean with disinfectant. But we should give or provide the contact time while using disinfectant. Contact time for hypochlorite is 2 minutes, and other disinfectant as mentioned by the manufacturer. And this floor cleaning is very, very important, and use appropriate disinfectant. And before using disinfectant, you have to remove the dust and use clean with detergent and use appropriate disinfectant. Then rooms, never use fumigation. Never do fumigation or fogging. There's no role in cleaning or disinfection of room. Because this fumigation is used for sterilization of fomites, like some articles, like the furniture, then not for microorganisms suspended in the air. Always remember, fumigation is not for removal of or destruction of microorganism in suspended air. This is only for sterilization of articles of fomites in the room. It has no role. Infant cot and incubators. Do not use phenolic disinfectants, can lead to hyperbilirubinemia in patients. Infant incubators, after cleaning, wipe with 70% isopropyl alcohol. Cleaning your housekeeping surfaces and eating utensils. Wear gloves when handling patient trays, dishes and utensils. Then clean with soap and water or a detergent or disinfectant, depending on the nature of surface and degree of contamination. Then cleaning soiled bedding, towels and clothes from patients. Previously, we used to do cleaning with hot water and with 0.1% hypochlorite. Now washing machines are available. Wash at 60 to 90 degrees centigrade with laundry detergent, followed by soaking in 0.1% hypochlorite for approximately 30 minutes and dried. No machine washing. If no machine, no machine for washing, then 0.1% hypochlorite for 30 minutes. And we can use hot water also. Rinse with clean water and let linens dry fully in the sunlight. And respiratory hygiene and cough etiquette. Respiratory and during that process, cover the nose or mouth when coughing or sneezing. Use tissues to contain respiratory secretion. Dispose of tissues in the nearest waste receptacle after use. Perform hand hygiene after contact with respiratory secretion, contaminated objects, materials. Prevent environment contamination in respiratory secretion. Can use triple layer masks to person who are coughing. Then encourage coughing person to sit at least 3 feet or 1 meter away from others in common waiting areas. You can do droplet precautions also. Cleaning and disinfection after patient discharge or transfer. Clean and disinfect all surfaces. Do not spray or fog, do fumigation, occupied or unoccupied rooms with disinfectant. You have to clean and disinfect all surfaces and high touch and non-critical areas, minimum touch and high touch areas. Then this is about the spill management, as already discussed. Then this is summary of ventilation in special areas. In ICUs, we should make sure that in ICUs, the room air exchanges should be more than 12 air current exchanges per hour. Is air exchanges per hour should be more than 12. Otherwise, this suspended microorganism in the air will be there and can lead to spreading of infection, providing this sufficient air exchanges. This will be diluted, and so make sure in ICUs and patient examination room and all, where AC should make sure more than 12 air changes per hour. This is about Spalding classification of medical devices, critical devices, semi-critical and non-critical. As already explained, critical devices are medical devices that enter into a normally sterile site. Here we need sterilization, complete sterilization. In heat labile instrument, we can use sterilant, chemical sterilant, some high-level disinfectant by giving them more contact time, like glutaraldehyde, 2.4% glutaraldehyde, SIDEX solution, and another one of orthophthaldehyde. We can give more contact time to make it as a sterilant. So critical devices, sterilization, full sterilization, the complete sterilization is needed. So we can use physical and chemical methods where high-level disinfectant should be given more contact time. Then semi-critical devices like endoscopes, here high-level disinfectant is needed. Then non-critical areas, which are items in contact with intact skin, here quaternary ammonium compounds can be used. Then this is a diagrammatic representation showing the susceptible to resistant organisms to disinfectants. Basic, the low-level disinfectant can be used for vegetative bacteria, lipid or medium-sized viruses. These are mainly enveloped viruses. And then non-lipid or non-enveloped viruses like polio, Coxsackie, hepatitis A, E. For that, we need intermediate level or high level disinfectant, mycobacteria also. Then bacterial spores are destroyed by sterilization process only. Then, okay, let's explain. And the common one we are using in our in your practice are stethoscope. It should be cleaned with the detergent and water, should be wiped with the alcohol-based hand sanitizer, then spirit, then BP coughs and covers. Cough should be wiped with the sanitizer or alcohol-based sanitizer. Then thermometer should be stored in dry holder and cleaned with detergent, soap and water, and wipe with this alcohol-based sanitizer. Then store in individual holder. Then preferably we can use one sterile one for each patient. Then injection and dressing trolley should be cleaned daily with detergent and water. After each use should be wiped with the disinfectant. Then storage of items, very, very important area. We should store the sterile item, protect the sterility until ready to use. Store to protect package from dust, moisture, and falling on floor. Transport only covered dry packages, handle to protect package integrity, and rotate sterile item first in and first out. Store and label for effective recall system. Expiration date and expiry date and even related sterilization that should be noted. Then sterile items wrapped in SMS paper, that is spun-bond, melt-blown spun-bond paper. It can be stored for up to 5 years, but normally we can store it, this SMS wrapped sterile items can be stored up to 28 days and wrapped in linen, but linen should have 140 thread count and can be stored for 1 week. And this is an article showing, does improving surface cleaning and disinfection reduce healthcare associated infection? Definitely, but we are here, they are compared the fresh disinfection with the fresh hypochlorite solution and use the hypochlorite solution and quaternary ammonium wipe. Here in by using quaternary ammonium wipe, it was not good, and also use the hypochlorite wipe and freshly prepared hypochlorite wipe, no growth in culture plate. This denotes that we have to use hypochlorite freshly prepared one only. Otherwise, no need of disinfection. No, nothing will happen there. There will not be any disinfection have taken place. So make sure these attenders or they are preparing fresh hypochlorite solution. After 24 hours, the potency of this hypochlorite will be lost. No need of using that disinfectant. That this article and guideline, this one for decontaminating fiber optic scopes. First, in every procedure, the cleaning is very important. Cleaning with the enzymatic detergent as soon as the scope is removed from the patient. This enzymatic detergent, this has some enzymes present, that is lipase, proteinase, chitinase, then cellulosinase and all. Then this will remove the organic matter. This organic matter, otherwise this organic matter will be the cause for persistence of microorganism in this scope. So enzymatic detergent, cleaning with enzymatic detergent is very, very important to remove all the organic matter from the scope. Then high-level chemical disinfection, like 2% glutaraldehyde or orthophthaldehyde can be used. Then cleaning, high-level disinfection. After that, rinsing with sterile water, then dry. The scope is forced air, then storage. Clean scopes should be transported and stored in sterile bags. So these are the guidelines for decontaminating fiber optic scopes, cleaning. Here, enzymatic detergent is very, very important. Then high-level chemical disinfection, then rinsing, drying through force by using force air, then storaging. These are the factors leading to outbreaks from endoscope or bronchoscope contamination. These are the factors: contaminated water supply, then contaminated brushes for cleaning scope lumen, improper manual cleaning prior to disinfection, biofilm inside. Biofilm, this is an extra one matrix form inside the scope, which contain plenty of families of plenty of bacteria, which are multi-drug resistant organism. And this biofilm will act as a barrier from affecting this antibiotic. So biofilm inside automatic washer, improper use of automatic washer, contaminated or expired disinfection reagent, inability or neglect to clean the suction channel, mechanical or design issues related to endoscope or bronchoscope. And humidifiers and nebulizers, single patient only, use only respicules, then clean and air dry nebulizer chambers daily and replace every 3 days. About some words about OT fumigation. No substitute for vigorous scrubbing, washing of surfaces, and cleaning of removal of organic matter. So fumigation, before fumigation, should conduct vigorous scrubbing. That is very, very important. Cleaning with detergent and fumigation. I have already mentioned fumigation is for sterilization of articles only. not for removal of organism in the suspended air. So environmental bacterial sampling in operation theaters should be limited to. So nowadays, bacterial sampling for swab and all we won't encourage, because it is limited to investigation of epidemics, validation of protocols, or changes made in materials which should influence the microbial content and renovation of OT. In these circumstances only, environmental bacteria sampling are needed. So these are the very important steps you should avoid. Double dipping. Should not use a syringe and needle to different patient. Syringe and needle to another patient or separate other patient. That is double dipping. Recapping of needle. If needed, do single hand scoop method. Keeping of multi-dose vial for more than 20 days. We can use, should not use, because we can keep this multi-dose vial for 28 days, but should not keep the multi-dose vial for more than 28 days. Never keep loaded syringe. So never do double dipping, never do recapping of needle, never keep multi-dose vial for more than 28 days, never keep loaded syringe. Then devices contaminated with HIV and hepatitis B viruses, use standard disinfection procedure, but we can increase the contact time. If we are using chemical high-level disinfectant, we can we can ensure to provide more contact time. Then this is about healthcare associated infections. The very important common 4 types of healthcare associated infection. That is one CORT, CLABSI, VAP, and surgical site infection. Prevention of healthcare associated infection by standard precaution and transmission based or specific precaution. And the contact precaution, infection control measure, contact precaution like hand hygiene, using of PPE, single-use patient dedicated equipment, patient placement, transfer of patient, disinfection of room, cohorting. These are the contact precaution, and we should do 5 moments of hand hygiene. And these are the care bundle for urinary CORT, insertion care bundle and maintenance bundle. These care bundles are evidence-based practices by which we can decrease the spread of infection. So insertion care bundle, like catheter, should be inserted only when appropriate indication is present. Only sterile items and appropriate sites should be used. Then catheter is inserted by non-touch technique with strict asepsis. Then closed drainage system must be used. Then catheter must be properly secured after placement, and maintenance bundle include daily catheter care. Catheter is properly secured at time. Drainage bag must be always above the floor, and bag should be below the gallbladder. Then, urinary bladder. Closed drainage system is used in all time. Then while collection of urine from bag, hand hygiene should be done. Then daily assessment of readiness for removal of catheter. Then this is for central line, insertion bundle and maintenance bundle, hand hygiene, use of maximum sterile PPE, size of the site of insertion is very important. Subclavian is preferred, less chance of infection. Then IJV, after that only femoral. Then skin preparation. Skin must be completely dry after use of antiseptic. Can use semi-permeable dressing. Document date and time of insertion. Then maintenance bundle, daily aseptic central line care. Then rub the hub, and for all, before doing all, hand hygiene must be performed. Daily recommendation of local signs of infection. Change of dressing with 2% chlorhexidine. Daily assessment of readiness for removal of central line. Then maintenance care bundle for mechanical ventilator, adherence to hand hygiene, elevation of head of bed to 30 to 45 degrees. This is to prevent oropharyngeal aspiration to respiratory tract. Daily oral care, that is not recommended. This has been removed. And no daily oral care can be done not with chlorhexidine 2% solution. Need of peptic ulcer disease prophylaxis, deep vein thrombosis prophylaxis, and daily assessment of readiness to remove mechanical ventilators should be documented. Then surgical site infection, pre-operative recommendation as antiseptic showers, pre-operative antiseptic showers. Hair removal is not necessary. If need, use clippers. Then skin preparation solution, then antibiotic prophylaxis and hand hygiene. Intraoperative procedure, the systemic antibiotic prophylaxis must be provided for all except clean surgeries 60 to 120 minutes before incision. Choice depends upon local antibiotic policy. Single dose should be given. Surgical hand disinfection, surgical site preparation with alcohol-based chlorhexidine antiseptic solution, peri-operative maintenance of oxygenation, post-operative measure, wound dressing, and systemic antibiotic prophylaxis prolongation is not recommended, but in certain circumstances we can prolong the treatment. Next, about biomedical waste management. Biomedical waste management rule 2016 amended in 2018 and 19. This is applied to all persons who generate, collect, receive, store, transport, treat, and handle any biomedical waste. Sorry. Occupier means a person having administrative control over the institution and the premises generating biomedical waste. Responsibility of every occupier is a safe and proper identification, handling, and segregating disposal of biomedical waste from laboratories and related facilities. Segregation, packaging, transportation, and storage. Untreated biomedical waste should not be mixed with the treated other waste. Biomedical waste containers or bags should be prominently labeled with biohazard symbol. Untreated biomedical waste should not be stored more than 48 hours. Ensure no spillage occurs during handling and transit of biomedical waste. And this is the new biomedical color-coded buckets we are following. That is, yellow bag is for anatomical waste, soiled waste, chemical waste including antibiotic, expired antibiotic, and cytotoxic drugs. Then blood bags with the blood, then laboratory culture, stocks or specimen of microorganism, live or attenuated vaccines, human and animal cell cultures, discarded linen, contaminated blood or body fluids. This is about red bag, contaminated recyclable waste. That is mainly plastic one. Waste from disposable items, tubings and bottings, intravenous tubes and sets, catheter and urine bags, syringes, vacutainers, gloves, then plastic petri dishes, then translucent white box. This should be puncture and leak proof, tamper proof. Sharp waste are discarded in this translucent white box. Syringes with fixed needles, needles from needle tip cutter or burner, scalpels, blade, any other contaminated sharps. Then blue bag for glasswares, broken or discarded glass including medicinal vial, ampule, then broken or discarded contaminated glass vessel. Then this is about conclusion of this presentation. Here, the hand hygiene has the important role in IPC practices. Hand hygiene auditing should be done in our ICUs. Then cleaning and disinfecting the environmental surfaces is a fundamental in reducing healthcare associated infection. Establish cleaning strategies to be used. Cleaning staff must be protected by using standard precaution and and they should get by including use of appropriate PPE, and also they should we should ensure the vaccination vaccination also. Then prevent environment contamination by containing respiratory secretion, manage biomedical waste as per existing biomedical waste management rule. And educate, this is a very important one. We can do in infection control prevention practices, educate for the stopping the spread of infection in our hospital and health. Because by giving repeated training, and only we can control this infection, healthcare associated infection. So education has the main role. It is everyone's responsibility. Thank you, madam.
Thank you, Dr. Jyothi, for that informative talk. We are not used to listening this for quite a long time now, and actually this is a very, very important topic, and it was very refreshing and bringing with so many new ideas and knowledge which we often just consider it as very normal or something, and this is the reason for most of the infections, and many infections will remain difficult to treat as so many resistant organisms are there. So any questions?
The screen stop here, Jyothi.
Any questions? Dr. Shija has asked regarding the decontamination of nebulizers and sigma-manometer cuff, etc., which you have actually already mentioned, but you can answer. One question is there in the chat box.
I only recognize it's a chlorine solution can be used, but Jyothi can tell more about it. That is the initial teaching we got.
That is the nebulizer and sphygmomanometer cuff and other daily use things.
I said for something.
Madam, nebulizer, we should clean it daily, madam. Clean it and dry it and discard it after 3 days, madam.
Okay.
No, only thing is sphygmomanometer cuff, it will be, I think, difficult with the chlorine solution. Am I right?
Yeah, rubbing with alcohols.
Yeah, that can be done. But baki everything we can use it a chlorine solution, I think.
Okay.
Dr. Jyothi was telling about the stethoscope chest piece also should be cleaned, isn't it?
Yeah.
Which we are not doing.
Actually, one preparation nowadays it is available. I got it as a compliment from some representative. This is for stethoscope cleaning.
Okay.
The name is Protec. Content is alcohol only. See, one doubt I got to Jyothi, that is 0.1% chlorine solution you're talking about it. What I learned is 0.5% and 1%.
Now it has changed to 0.1%, sir. And
okay. So no need of 0.5% and 1%.
0.5% for blood contaminated with blood only. 0.5%.
Otherwise, 0.1%.
0.1 is enough. But the chlorine, disinfectant should be prepared, freshly prepared, and the availability chlorine should be checked.
Okay. And how long you can keep it? What I learned is 24 hours you can.
That's in 24 hours.
Contribution.
Both talks are excellent. A lot of learning points from both of you. And few of our experience, and Bharati Madam is here from Thrissur. In the neonatal nursery, we had a series of infections due to Pseudomonas, and we are investigating. And what we found was a common water source from which Pseudomonas was isolated. So that was Dr. Jyothi was pointing out that. So when a hospital is being built, at present I don't know whether they are consulting about the future possibility of this sort of high-level organisms and the preventive measures to be started even at the time of construction. I mean, there are two ways in which you should be considering. Areas where the susceptible populations are kept is one, and the other, the areas where the resistant organisms as sources. The first situation is newborn nursery, ICU, burn unit, and theaters. And those areas, the water supply should be separate from the common water supply source so that you can periodically check the source of water going into those high risk areas. All those high risk areas, you expect the high susceptible population. The burn unit is there, an ICU is there, and the theaters also. Water supply should not be common. So this should be discussed at the time of the preparation or the construction of the building itself. Then about the other areas where the people donate the organisms, like we know multi-drug resistant tuberculosis, pulmonology, OP, and there is a high chance of these organisms, and we'll be keeping them. Just like that, the area of immunology OPs. So in Calicut, Dr. Geeta is running an investigation of high susceptible population where they are also likely to have these resistant organisms. And that sort of areas, we need special precautions because the common source of this organism can spread to the other areas of the hospital. So those areas need to be segregated in a particular manner. Like your diabetic clinic where highly susceptible, these dangerous organisms are likely there on the foot and ulcers and gangrenous and all. So high organism sources to be separated in a particular area, in a group of areas, in a hospital environment. So that is one suggestion. Okay, what's your suggestion, Dr. Jyothi?
Sir, very important, sir. We should suggest the sufficient supply of clean and sterile water, sufficient supply should be maintained in all hospitals, sir. And the disinfectant like Dettol and all, they are a culture medium for this bacteria, Pseudomonas and all. And also Burkholderia cepacia is a emerging bacterial pathogen causing hospital-acquired infection. So it's very important, sir, providing sufficient
water
supply, sterile water supply.
Recently, we had these organisms from the nebulizer from the normal saline, Dr. Bennet, from the normal saline. There's how we could overcome this was using the without the normal saline, the respiratory solution with the normal saline, we replace with the diluted form of the already pre-diluted form of this nebulizing solutions of salbutamol. And saline solution to be used for multiple people, the smaller volume will not be available. That is one problem.
That problem is there, sir. Repeated using, the contamination chances also will be very high.
Actually, we have actually read recently in the Lancet like neuromyelioidosis, a very dangerous organism, which was happened in a dental clinic where the saline was flushed.
Yes.
And some 10-12 people died actually in Tamil Nadu. The article has come in Lancet. So that hospital also it is closed or some other function it's going on. But it is so dangerous, isn't it? The saline is pushed at high, it is under pressure, it is pushed into our own mouth. So these are the things that we never think about these things.
Madam,
myelioidosis,
Burkholderia pseudomyeli is a soil saprophyte, madam.
Okay.
So the water should be, that is why the sterility of water should be checked. And
in the dental clinic, that is because all infections, they came together in a place and they identified the organism and the source also they identified.
Okay.
One doubt regarding the how to decontaminate the monitors. It's asked by Dr. Maya Menon.
70% alcohol.
25% alcohol.
70%.
70%.
That is our sanitizer will be okay.
Yeah.
Yeah, like Stetta and all your cleaning.
Okay.
Then thank you.
Parvati madam, any comments?
Both talks were highly informative, madam. I had worked with Dr. Jairam Panikar for few months in Calicut, and my daughter is a microbiologist, Dr. Anjali. She is working in Thrissur Medical College. I think she is working with the hospital infection control program. And in Amala, we had Dr. Mabel madam. She is also quite good. So we have good experience with all these microbiologists. So very nice talks.
Dr. Bennet, one more point which we need to consider in the coming years is many of the hospitals, once they are constructed, more and more buildings will be constructed. It's a continuum. So when there is a construction work going on in the vicinity where treatment also is happening, there is a chance of fungal infections.
Very high chance.
Very high chance. So that also need to be discussed with. So hereafter, this discussion should be with the administrators and the consultants.
These are all legal things.
Yeah.
These are with the government and private. Both it is there competing for this construction work.
Construction work. Always construction work going on in almost all the hospitals, just like our roads. Just like our roads.
Right. No dearth of money for both the places, both in private and government. Okay.
Sir, ഞാൻ കുറച്ച് AMR-ന്റെ കുറച്ച് കാര്യങ്ങൾ പറയാം.
Antibiotic, okay.
അതെ മാഡം. കേരളയുടെ antimicrobial this program is KASAP, Kerala Antimicrobial Resistant Strategic Action Plan. This Trivandrum Medical College is the nodal center, and Dr. Aravind, HOD Infectious Disease, is the convener, and Dr. Manjusri, HOD Microbiology, is the nodal officer. And we are, this is an One Health approach, madam. Here, all the sections like veterinary and poultry, then pollution control board, and then food safety, all these departments. All these departments are involved on, and drug control, they are doing. Drug controller, they have അവരൊരു നല്ല ഒരു ഭയങ്കര ലീഡിങ് കുറെ പ്രോജക്റ്റുമായിട്ടാണ് വന്നേക്കുന്ന എൻ പ്രൗഡ് പ്രോഗ്രാം. എക്സ്പയർഡ് ഡ്രഗ്സ് ഒക്കെ ആൾക്കാർക്ക് അതിനെ ഡിസ്കാർഡ് ചെയ്യാനായിട്ട് എൻ പ്രൗഡ് പ്രോഗ്രാം. പിന്നെ ഒരു ഓപ്പറേഷൻ അമൃത് എന്ന് പറഞ്ഞാൽ ആന്റിബയോട്ടിക്, ഇങ്ങനെ ഡോക്ടേഴ്സിന്റെ പ്രിസ്ക്രിപ്ഷൻ ഇല്ലാതെ ആന്റിബയോട്ടിക് കൊടുക്കാൻ പാടില്ല എന്ന് പറയുന്ന അമൃത് പ്രോഗ്രാം. ഇതെല്ലാം ഇപ്പൊ കാലിക്കറ്റിൽ ഒരു സ്ഥലത്ത് മാത്രമേ അതിനെ നടന്നിട്ടുള്ളൂ. ഇനി കേരളത്തിൽ എല്ലായിടത്തും they are expanding the program, and by end of December 2025 the Kerala will become an antibiotic literate state. അതാണ് നമ്മുടെ എയിം ഇപ്പം.
And this surgery, actually this pre-surgical only single antibiotic, in case they are using it, and the infection chances are very less. Actually, like otherwise the more and more resistant organism.
പിന്നെ മൈക്രോബയോളജി ഡിപ്പാർട്ട്മെന്റില് കേരളത്തിന്റെ ഡിഫറെന്റ് ഏരിയാസ്, വി ഹാവ് 59 കാസ്നെറ്റ് സൈറ്റ്, മാഡം, including health services also. And we are making annual biogram, state antibiogram every year. from 2022 we are preparing. And പിന്നെ നമ്മുടെ ഹോസ്പിറ്റലില് ആന്റിബയോഗ്രാം ഇതൊക്കെയാണ് നമ്മുടെ ഇവിടെ ചെയ്യുന്ന
this veterinary practices of giving antibiotics.
അതെല്ലാം കുറെ സ്റ്റോപ്പ് ചെയ്തു.
It will become like we will also become resistant like that.
അതെ മാഡം. പിന്നെ നമ്മളിപ്പം മെഡിക്കൽ കോളേജിൽ എല്ലായിടത്തും തന്നെ അവെയർ WHO അവെയർ ക്ലാസിഫിക്കേഷൻ അതിന്റെ റിപ്പോർട്ടിംഗ് സിസ്റ്റം ആണ് ഇപ്പം നമ്മൾ പ്രൊവൈഡ് ചെയ്തേക്കുന്ന. ആക്സസ്, വാച്ച്, റിസർവ് ഡ്രഗ്സിന് ഡിവൈഡ് ചെയ്ത് അങ്ങനെയാണ് നമ്മൾ റിപ്പോർട്ടിംഗ് ഫോർമാറ്റ് തന്നെ ചേഞ്ച് ചെയ്തു. ഇതൊക്കെയാണ് ഇതുവരെ ചെയ്തേക്കുന്നത് മാഡം.
There is a market difference is there. Market difference.
കോളിസ്റ്റിൻ റെസിസ്റ്റന്റ് എവിടെയെങ്കിലും കിട്ടി ഏതെങ്കിലും മെഡിക്കൽ കോളേജിലോ പ്രൈവറ്റ് ആൻഡ് ഗവൺമെന്റ്, they will send to us, that isolate will be sent to us and we will confirm it and send to NCDC for confirmation. അങ്ങനെയൊക്കെ ആകുമ്പോൾ നമുക്കത് ചുമ്മാ റിപ്പോർട്ട് ചെയ്യാനും പറ്റത്തില്ല. കോളിസ്റ്റിൻ എല്ലാം കൺഫേംഡ് ആണ് റിപ്പോർട്ട് ചെയ്യുന്നത്. അതുപോലെ റെസിസ്റ്റന്റ് സാൽമോണല്ല ടൈഫി അതെല്ലാം സെഫ്ട്രിയാക്സോൺ റെസിസ്റ്റന്റ് അതെല്ലാം നമ്മൾ NCDCക്ക് പ്രൊവൈഡ് ചെയ്യും. കേരളത്തിന്റെ ഡിഫറെന്റ് സൈറ്റ്സ് നിന്ന് they are sending to us and we will confirm first, we will do it first, and if any resistance is there we will send to NCDC. അതാണ് നമ്മുടെ ജോലി. ഇതൊക്കെയാണ് we are doing, compiling all the data from different centers and making state antibiotic.
It's great job actually. Srijit is there. Can we wind up the session? Srijit.
Okay, madam. Then, so I thank both the speakers, Dr. Bennet sir and Dr. Jyothi madam, for sharing their time and wisdom with us, and also updating about the antibiotic policy currently running in Kerala state. And hope you to see in the next episode of Tuesday series. And we will have another program, PG Club program, on Thursday. So, Purushottam sir, please join us on Thursday also. Okay.